how much it is safe to drink. So the best thing to keep in mind is that there is no safe time or safe amount to drink during pregnancy. Alcohol and the developing fetus. Alcohol is a teratogen, and a teratogen is a substance or condition that disrupts typical fetal development in the offspring as a result of gestational exposure and causes birth defects. So what that means is that alcohol can cross the placenta and interfere with the developing cells in the fetus. There are two rules governing teratogens, and that is the greater the dose, the larger the anticipated response. And the pattern and timing of the dose affect the type and severity of the response. So what this means is that depending on how much alcohol was consumed and when the alcohol was consumed means that you'll have different effects within the fetus. This is why fetal alcohol spectrum disorder is a spectrum disorder, and it is also why they say that no child affected by FASD is the same. Prenatal exposure to alcohol can cause 4 distinct outcomes, and those are death, malformation, growth deficiency, and functional deficits. There are other factors that influence whether or not a child will be born with FASD. Exposure to alcohol is, of course, the main factor. However, you have to also factor in maternal age and health, prenatal care, the condition of the mother's liver, and the baby's ability to metabolize alcohol. Just because a woman drinks during pregnancy does not necessarily mean that her child will be affected by fetal alcohol spectrum disorder. So alcohol affects whatever is developing in the fetus at the time, keeping in mind that the brain and central nervous system are developing in the fetus throughout pregnancy, so they are always at risk of being affected. And most importantly, FASD does not discriminate. It can be found in any socioeconomic or cultural group. Wherever alcohol is being consumed, there is a risk of FASD. The world of FASD is a world full of acronyms. What you need to know is FAS, PFAS, ARND, ARBD are diagnostic terms. FAS is fetal alcohol syndrome, and that was what was discovered in 1973. Later came the diagnoses of partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorder, and alcohol-related birth defects. These diagnoses are based on how an individual ranks in 4 categories, including confirmed prenatal exposure to alcohol, facial features, growth, and brain functioning. So people often assume that individuals with partial FAS as their diagnosis thought to be higher functioning than an individual with full FAS. And this is a bit of a myth. So the only difference between an individual partial FAS and an individual diagnosed with full FAS is that individuals with partial FAS do not have the facial features of FASD. However, an individual will only present with the full facial features if alcohol is consumed during 3 specific days in early pregnancy. Also, individuals grow out of facial features. So this is why facial features are not a good indicator of whether or not an individual has FASD. The term FAE, so fetal alcohol effects, you may also hear, and this is an outdated term but is still used in the US. It is not a diagnostic term. It is extremely hard to get a diagnosis of fetal alcohol spectrum disorder. There is no simple test that can be done, so a child has to visit a multidisciplinary team. These teams are very expensive, and there is a long wait list. So the multidisciplinary team in Victoria has a current wait list of 1 year. Members of this multidisciplinary team are a pediatrician, a psychologist, an occupational therapist, a speech and language pathologist, and a social worker. If a child does not get a diagnosis before they turn 18, then they have to pay for a diagnosis. So if the individual lived on Vancouver Island, they would have to pay around $5,000 to be assessed at the Asante Centre. That's why there is a large push to have individuals diagnosed when they are children, is because that it is free. It is extremely hard for a child to get a diagnosis if there is not confirmed exposure to alcohol. This has ramifications for children involved in the foster system or children who have been adopted and do not have that information readily accessible. There is a disproportionate number of children affected by fetal alcohol spectrum disorder within the foster system and who live with adopted families. For children who are still with their birth families, this means that somebody within the family has to be able to admit that drinking occurred during pregnancy. And this is often a very hard and traumatizing thing to do, especially for birth mothers. Finally, if a child is functioning well on the day that they get access, they may not get a diagnosis. And different diagnostic clinics are more conservative than others. So one clinic may not give a child a diagnosis, whereas another would. So 2 important things to keep in mind as a teacher. One is you will have children in your class who do not have a diagnosis or any support and will not be able to get a diagnosis. The second is the diagnostic process can be extremely stressful to families and is often frustrating because it does not immediately qualify the student for any resources or support. Most services, including funding and respite services, are based on an IQ rating, which is extremely frustrating for families because many individuals affected by FASD have a low average or high average IQ and therefore do not qualify for those services. On the other hand, benefits that go with having a diagnosis include the diagnosis comes a detailed report about the student's functioning level. The student's case manager at the school will generally have a copy of this report, and the student would therefore have an IEP, which should be a reflection of the report's recommendations. So a really easy place to go to get some strategies or ideas about how to best work with the child. Also, generally, if a student comes to you with a diagnosis of FASD, they qualify for chronic health funding and therefore should have some supports in place within the school system. What every teacher needs to know about FASD. FASD is an invisible disability. This is often a disadvantage for individuals affected by FASD because people constantly expect them to function according to their chronological age, when developmentally they may be a lot younger. People also tend to be a lot more free with comments and criticism if they do not see an individual is visually disabled. This goes for other students as well. So students are harsher on their peers if they do not see a visible reason for their deficits. Every individual affected by FASD will have different strengths and challenges based on when alcohol was consumed and how it interacted with their developing cells. This means that strategies that worked for one student affected by FASD cannot be expected to always work for the next student. An individual affected by FASD IQ score is not a very good indication of their functioning. So an individual affected by FASD could have an average or even higher IQ, but still struggle with daily living skills. This is because individuals with FASD typically have a low adaptive quotient. This means that they struggle with skills that are required for them to be successful in daily life. For example, how to get dressed, personal hygiene, cooking and cleaning. So don't let a high IQ fool you about a student's functioning level. Oftentimes, students affected by FASD can tell that they are different from other students, but don't know why. And this is really hard on their self-esteem. Remember when teaching that oftentimes students affected by FASD's greatest desire is to look exactly like all the other kids. So create strategies that will not embarrass the student, and remember that if the student does have a meltdown, they're going to be upset about having lost it in front of their peers. Students with FASD have generally experienced a lot of failure. So this can be tied into having an invisible disability and always having people expect higher performances than is possible from them. One consequence of this is a disproportionately high dropout rate for students affected by FASD, as well as a higher chance of secondary disabilities such as depression, anxiety, and other mental health concerns. Individuals affected by FASD have a disproportionately high suicide rate. This is why it's extremely important to take a strength-based approach when working with students affected by FASD.